Welcome to the ONC proposed rule, Health, Data, Technology, and Interoperability. My name is Lauren Reyes with Kaufman and Associates. I will be assisting with the logistical support for this Zoom session. To ask questions, click the Q&A button at the bottom of your screen. However, please note that there are restrictions to what questions can be answered due to the Administrative Procedure Act. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Vaishali Patel.
Thank you all for joining our webinar today to discuss the insights condition within the proposed rule. My name is Vaishali Patel, and I'm Deputy Director of ONC's Technical Strategy and Analysis Division. Joining me today are Michael Whitty, a Public Health Analyst, and Dustin Charles, a Senior Policy Analyst, both within our Office of Policy. In addition, Stephanie Lee in our Office of Policy within our Regulatory Affairs Division will also be joining us. Michael Whitty led the draft development process of the measures, including overseeing the contract with Urban Institute and participating in multiple stakeholder engagements to ensure the measures that we'll be talking about today reflect programmatic and end user needs. And Dustin and I, along with our data analysis team and other ONC colleagues, including Stephanie Lee, helped refine and specify the measures and help develop other aspects of the insights condition proposal. Next slide, please. So this is the disclaimers and public comment guidance. I'm not going to read this slide word for word, but just to highlight a few points. These slides are based on the proposed rule. And while every effort has been made to ensure the accuracy of the restatement of the proposals, this presentation is not a legal document. The official proposals are contained in the proposed rule. So just as guidance, our slides are kind of like cliff notes. It's meant to serve as a summary and a guide, but you really need to read the proposal to get the full details. In terms of answering questions, ONC cannot interpret the information in the proposed rule, nor clarify, nor provide further guidance. ONC also cannot address any comments made by anyone attending the presentation today, or consider such comments in the rulemaking process. So if you want to make a comment that we can consider, please submit those comments through the formal comment submission process as specified in the Federal Register. And Stephanie Lee will be discussing how to do that at the end of this presentation, because the process is a bit different for the measure specifications that we'll be discussing today. And then finally, this presentation was produced and disseminated at U.S. taxpayer expense. And Michael Whitty, I'm going to be handing it over to him, will provide some background related to the insights condition, including how it was developed. Michael?
Thanks, Vaishali. So next slide, please. So as many people are aware, the Cures Act is really where this all started. The Cures Act required that HHS establish the EHR reporting program to measure the performance of certified health IT in a variety of areas. And they also required, in the Cures Act, Congress required that the program be implemented as a condition and maintenance of certification requirements for certified health IT developers. As we went through the development, we thought through how this should work, and we decided to implement the EHR reporting program as the insights condition and maintenance of certification program, and also known as the insights condition, to make it clear exactly what we were talking about and not get confused with any other reporting programs. Next slide, please. Again, the basics. So the background that I'm going to go through. Next slide. So the measures were developed, and there was this very detailed process laid out in the Cures Act, and we followed that process. So we started with market research, and then at the same time, we engaged a contractor, the Urban Institute, who did more research. And we did a whole series with them of stakeholder engagements with provider organizations, with developers, with other stakeholders. And Urban did their own research, and they came up with a list of early draft measures that we then took to our Federal Advisory Committee, the HITAC, and had a task force, the EHR Reporting Program Task Force in 2021, and they provided detailed feedback on those initial measures. And then Urban took all that feedback, including feedback from a public comment period that happened at the same time, and revised them into draft measures. And then they did feasibility testing and additional research on those measures, and then worked with ONC SMEs to revise them again and come up with a better list, the current list of measures. Next slide, please. These are the measures. So the Cures Act, as I said, required this development, and it specified that the reporting should be on the domains including interoperability, usability and user-centered design, security, and conformance certification testing. And ONC is implementing this program a step at a time, and the first step is to focus on interoperability. So this set of draft measures is based on all the research that I talked about a minute ago, and it relates, each measure relates to a given area and within interoperability domain, and is related to a specific criterion or multiple criteria within the certification program. So you can see there's a link from the topic area to the measure to the criteria, so that it gets specific, and you can see what those are here. The next slide, please. So the developers of certified health IT would be expected to report as required by each measure if they meet, this is not everybody, but only if they meet the following criteria. They have to have at least 50 hospital users or 500 clinician users across their certified health IT products. Their products have to be certified to the criteria or criterion that you saw above that's related to the measure. And the developer has to have users of that applicable criteria associated with the measure. So if nobody's using it, they're not eligible to report on that. Otherwise, they would report that they aren't eligible. They don't meet the criteria to report on that. So they don't meet the qualifications. So they wouldn't report data. They would just report that they don't meet the qualifications. Next slide. So what's going to be submitted and how? Measure results are going to be aggregated and reported at the product level across versions in the given formats. Why product level reporting? Because we think that product level data would provide insights on how performance on the measures varies by market, so inpatient, outpatient, specialty, and by capabilities of products. Whereas if we rolled this up all the way to the developer level, we wouldn't be able to tell those kinds of differences. A product level focus is also aligned with other reporting requirements that allow for product recording, such as the real world testing, condition, and maintenance and certification. Documentation should help with correctly interpreting the measures for the developers. You can see the documentation that goes along, the documentation that can be optionally submitted with to clarify their data, and the mandatory documentation on how they got their data and what methods they used. So that required documentation should include the types of data sources used, how the measures were operationalized, including any specified definitions, assumptions, information about the providers or products that might have been included or excluded separately, and a description of how the data collection was executed. So they can also, as I said, submit descriptive or qualitative information to provide context on their submissions. They'll do this by a web-based form as specified in the Cures Act, and then it'll be made publicly available on ONC's website. ONC is going to designate an independent entity to do the collection of the data, and the ACVs will be involved in ensuring compliance. And I hand it back to Vaishali, who's going to talk about the details and the time frames.
Next slide, please. Great. So in terms of the reporting frequency and timeline, the reporting of the measures will be phased in over 2 years. We believe that a phased approach will allow more time for developers to implement the measures and for us to learn from the experiences of implementing the first set of measures. We're prioritizing the reporting of measures that have particular policy importance. So year 1 will start with measures related to individual access, public health exchange, and application supported through the certified health IT measure. Year 2 will follow with the rest of the standards adoption and conformance measures and the clinical information exchange measures. And currently we are proposing that year 1 start with April 2025. Next slide, please. So in terms of the reporting frequency and timeline, there are key steps involved in the process as we envision it. The first step is data collection. The measure should reflect the 6-month reporting period. As shown in this figure, this would occur from the beginning of April through the end of September. The second step in the process is assembling the data. And developers would have 6 months to collate the data once it's collected into the specifications required for the measure. So as shown in this figure, this would occur from the beginning of October to the end of March. And then the last step of the process would be reporting the data. Developers would have 1 month during which they would need to report the results. They can report it at the first of the month or the last day of the month that it is due. As shown in this figure, this would be during the month of April. Given that the measures we're proposing would be submitted every 6 months, the steps I described would repeat again with measures starting in October, as you can see in the second reporting period on the timeline, instead of April. And the 2 submission windows would be April 1st to April 30th, and the second submission window would be October 1st to October 31st. And this aligns with the reporting for the attestations conditions of maintenance and certification and the real world testing requirements. Next slide, please. So one of the things we want to point out is we have, although everyone's welcome to provide comment on any aspect of the proposed rule, we wanted to bring to your attention a few areas for feedback. We would like comments on the overall program processes, specifically the frequency of reporting. Is the reporting that we've proposed for every 6 months the right cadence? Does 12 months for collecting and collating the data provide adequate time to generate the measures? And we'd also welcome comments on the phased approach that we've proposed and the timeline, which is, as of right now, we've proposed would start in April 2025. Another aspect of the reporting we'd like feedback on is related to the submission process and the mechanism for reporting, which Michael Whitty described. So including, the reporting at the product level versus the version level, which would be more detailed versus the developer level. And we've set thresholds to set the minimum qualifications for the insights condition. And these were based on data that was available to ONC, and our desire to cover a wide swath of both the inpatient and outpatient ambulatory care settings. However, we welcome, any other alternative approaches to what we've proposed, and there are more details on that in the proposed rule. And then finally, we'd welcome comments on other issues. Are there specific hardships that health IT developers of certified health IT may encounter in implementing the insight condition that ONC should be aware of that we're not already aware of? So it's just an opportunity to really provide feedback on our overall programmatic approach. And Stephanie Lee will be describing the process for submitting the comments related to some of the areas that we flagged in more detail. Next slide, please. All right, so now we're on to the proposed measures. So put your seatbelts on. Next slide, please. So before we get into all the details of each of the measures, I wanted to just first set the stage and go through the different formats of the measures. There are various types of measures that we've proposed. Most, but not all of the measures have several numerators and denominators so that multiple metrics can be generated. A numerator may be paired with a few different denominators in some cases to generate different metrics. And we'll talk through this as we go through the measures in more detail. Other measures are simple lists of data, counts, attestations. Additionally, in some cases, there are the same denominators across a number of different measures. For example, several measures call for the number of encounters or patient visits as part of the denominator. So, and just to be clear, the reporting consists of what is called for in the measure, whether that's the numerator, the denominator, the counts, the attestations, not the generation of percentages or other metrics that one could generate through, the collection of these measures. What ONC is envisioning is that ONC would be generating those metrics. What we are proposing is that the reporting would consist of what we are outlining in terms of the measures themselves. Another aspect of the measures is that some measures call for stratification. And so what do we mean by that? Stratifying involves breaking out a numerator or denominator by a particular category, which would allow for deeper understanding of the overall aggregated results. So just to walk through a very simple example of stratification, cupcakes. Cupcakes can be stratified or categorized by different characteristics, such as flavors, type of frosting, by whether the cupcake has any sprinkles on it. So looking at the illustration that's on this slide, there are a total of 5 cupcakes in aggregate. If we stratify by the color of frosting, 2 out of 5 have red frosting, 2 have a dark gray frosting, and 1 has a light gray frosting. And we can generate metrics from that, such as like 40% of cupcakes have red frosting, 40% have dark gray frosting, and another 20% have light gray frosting. But basically, it allows us to not only look at the aggregate in terms of the total number of cupcakes, but also break it out by different characteristics. And similarly, as we go through the measures, we'll talk through how we want to break out an overall number by different characteristics, which will shed light on interoperability in a deeper way. Next slide, please. So there are 2 measures that relate to the exchange and to the clinical care information exchange category of measures that we have. The first measure is the CCDA documents obtained using certified health IT by exchange mechanism. And that measure captures the volume of consolidated CCDA documents obtained via different exchange mechanisms via patient volume. And so the question that this measure helps us answer are, what methods are being used to obtain CCDAs, and to what extent are CCDAs obtained in relation to patient volume? So in other words, when patients go to a different healthcare provider, to what extent are CCDAs obtained, either received or queried, and by what mechanism? So this measure helps shed light on how certified health IT certified health IT supports exchange of health information in relation to patient volume, and monitoring the volume of exchange by these various mechanisms over time is really critical to informing a number of key ONC policies that support exchange and interoperability, such as TEFCA. Next slide, please. So the second measure within this domain is CCDA problems, allergies, and medication reconciliation and incorporation using certified health IT. This captures the extent to which CCDA documents that have been obtained are subsequently reconciled and incorporated as part of a patient's record. So in the first measure, we're really focused on the methods being used to obtain CCDAs and to what extent those CCDAs are shared as part of an encounter. In this second measure, what we're focused on is once the CCDAs are obtained, how are they subsequently used as measured by the incorporation of the data that's within the CCDA. And the benefit of this measure is that it'll help us assess how certified health IT supports the actual use of external information for downstream use. Next slide, please. All right, so for these, now I'm getting into what I'll call the measure specification. And these are two measures that are listed here, both the measures that I just outlined. And both the measures that relate to clinical care exchange have the same denominators. For the denominators, we're proposing encounters, unique patients, and unique CCDAs, because looking at the volume of documents obtained alone, which are the numerators, is really difficult to interpret unless you understand how many patients or encounters those documents are associated with. So we're proposing to measure the volume of unique CCDA documents obtained using different mechanisms rather than CCDAs overall, because there may be duplicative documents. Given that there may be multiple visits by patient, looking at the unique number of patients would also make it easier to interpret the results. The first measure's numerator focuses on the volume of CCDAs obtained by method of exchange. So the term obtained refers to both the receipt of CCDAs through querying as well as through the receipt of these documents. And we have the volume of exchange separated or stratified by the different methods. So direct messaging, local and national networks, the developer-specific networks, and then the other category is methods not listed above, excluding eFax. So therefore, the volume of documents would be reported by the methods that are listed there on the left. In the second numerator, we focus on the specific types of CCDA documents that are incorporated within EHRs. These include CCDs, referral notes, and discharge summaries. We are proposing to measure the number of these documents that are obtained and were incorporated across all types of exchange mechanisms supported by Health IT. And just to note that this numerator captures the incorporation of all available CCDA documents, that I just specified of the types, but it's not tied to a specific event such as transitions of care. As noted on the right-handmost side of the presentation slide, there are several metrics that we can generate from the different combination of the numerators and the denominators. As an example, the percentage we can report out on the percentage of patients with an encounter that had an associated CCDA document. Another example is the percentage of unique CCDA documents obtained by the different types of methods. So direct messaging, via network, whether that's the local, regional, national, or the developer-specific network. And so it provides a number of different insights into the methods of exchange and how the information, once it's obtained, is whether it's used or not. Next slide, please. So with regards to this specific measure, we have some specific areas that we'd like comment on that are listed here. First, we're interested in feedback on whether we should reduce the number of exchange mechanisms for this first measure and how this should be done. This could be done by combining all types of networks into one category. That would also include the developer networks within the local HIE and national networks. We could also do this by combining direct messaging with the other methods into one category. So we'd be interested in some feedback on that. We also want input on the value of focusing on these different document types for the CCDA incorporation measure. And then finally, we'd like feedback on the issue of duplication of CCDAs. We are aware that this is a phenomenon that is occurring. We don't know to what extent it is occurring. So we have a few questions here that are listed here that we'd like some insights on that would help us refine the measure further. Next slide, please. All right, so now we're moving on to another measurement domain, which is standards adoption and conformance. The first measure that I'll be going through is the application supported through Certified Health IT, which captures how Certified Health IT is supporting the app ecosystem. The key question that's answered by this measure is what apps are connected to Certified Health IT products? This measure shall provide greater transparency regarding the apps that are connected to Certified Health IT, including whether apps are connected to different Certified Health IT products. Next slide, please. So there are a number of categories listed here. And the categories that we've proposed were informed by app category taxonomies from the published literature. This taxonomy or way of categorizing apps may evolve over time, but we believe that these categories should characterize a large majority of the current market. We really wish to capture, I should say that, there's a variety of characteristics that we are interested in, including the intended purpose of the app, the intended user of the app, the status of the app, which means like whether the app is actively being used or whether it's just an app that may be registered but not be in production or not have any users. And to date, some Certified Health IT developers have public app galleries, which have some information on apps. However, only a subset of developers have such galleries, and the galleries may not include all apps that are currently connected to Certified Health IT. Furthermore, not all information that we are requesting here is included currently in the app galleries. And so, our goal is to provide greater transparency regarding the app ecosystem by generating a list of apps, including their characteristics that are connected to Certified Health IT. And we are proposing that the app registration process, which is required under the G10 criterion, might provide an opportunity to gather this information as part of existing workflows, though would welcome comments on other approaches as well. Next slide, please. So the next two measures shed light on how functions that enable the export and downloading of electronic health information are used in Certified Health IT. This first measure, the electronic health information export through certified health IT, captures the use of certified health IT to export single patient and patient population electronic health information. The second measure, the use of FHIR bulk data access through certified health IT, captures the volume of bulk data downloads relative to the number of certified health IT deployments. Both these measures together really help address the question, to what extent are electronic health information export and bulk FHIR capabilities being used to support the movement of data from EHRs? Next slide, please. So this first measure, the electronic health information export measure, there are two components to it. One is a simple attestation, which indicates whether an eligible product enables direct to individual electronic health information export. The second component is reporting a simple count, the number of full data electronic health information export requests that are processed or completed during the reporting period. So this count then would be stratified by whether the electronic health information export is a single patient export or a patient population level export. An example of a metric that could be generated from the attestation and count data are, like, for example, the percentage of products certified to the B1 criteria that support the direct to individual electronic health information export capability. Another potential metric is just a count of the full data or electronic health information export requests processed by whether it's single patient versus population requests. So what percentage of the total number of requests processed were at the patient population level versus the single patient level. Next slide, please. This measure, the use of FHIR bulk data access, consists of one denominator, which is the number of distinct health IT deployments or installations across clients. This denominator allows us to determine the use of bulk data download requests completed for exporting all data for patients per client. Like the volume of clinical exchange measure that I went through, the first measure, knowing the denominator really helps us interpret the numerator. So the volume of documents, for example, based on the number of counters, in this case, the number of requests versus the number of deployments that relate. So it just helps us interpret. The second numerator, in combination with the denominator, also provides insights into the use of this capability across clients. So this is seen in the potential metrics that we'd be able to generate, that are listed here. Ultimately, these metrics would allow us to determine the extent to which the requests for patients' data as called for in the G10 criteria are being supported and used. So, for example, the percent of certified health IT deployments with at least one successfully completed bulk data download request really tells us the breadth of usage across the country, potentially. So, next slide, please. So this measure within the standards adoption and conformance really focuses on the use of FHIR in apps supported by certified API technology. It captures the volume of FHIR resources that are transferred in response to API calls from apps connected to certified API technology, looking at it by FHIR resource type. So this measure will help us answer questions related to the breadth and depth of FHIR use and shed light on its uptake, how it's implemented, and how it's used. So this measure ultimately will provide visibility into industry adoption of standards required by the certification program and provide essential data to inform standards development work that's ongoing. Next slide, please. So this measure's denominator is the number of distinct certified API technology deployments across clients. The numerator focuses on the number of API deployments with at least one FHIR resource returned or transferred in response to a call. Now, this measure has a lot of parallels with the measure that I just went through, in the sense that it's really trying to look at the breadth of active use and uptake of a particular standard here. So the other numerator is the number of FHIR resources returned or transferred, so the volume here in response to a call by resource type. Now, the resource data will help standards development organizations and ONC prioritize resources that may need further refinement. And although we've previously researched and tracked the total number of apps connected to APIs managed by health IT developers of certified health IT using publicly available data from health app galleries that I mentioned, where only a subset of developers have those, there's very little information that's been reported on the volume of data being transferred using certified API technology by end users. And in this measure, we call for stratification by type of endpoint, by FHIR version, and by US core implementation guide. In terms of the patient-facing versus non-patient-facing, requiring health IT developers of certified health IT to report FHIR resources transferred in response to calls from these two different endpoint types would provide insights into the types of data elements used by patients versus the types that are used by other types of users, such as clinicians. In terms of the US core implementation guide and FHIR version, while health IT modules certified to G10 are required to respond to requests according to the FHIR version release 4, we are aware that in the future, there will be newer versions of FHIR supported by newer versions of US core implementation guides. So gaining insights into the use of these implementation guides would help inform ONC regarding the variability in the implementation of FHIR across developers. And knowing which FHIR and US core implementation guides are in use would provide insights into where the industry is currently and where it may be headed with regards to implementation of specific versions of FHIR. Next slide, please. All right. So this is just an example of a table that shows how the second numerator, the number of distinct certified health ID deployments, which returned at least one FHIR resource in response to a call, is stratified by the different categories that we called for. So by type of endpoint, by type of implementation guide or version of implementation guide, by FHIR version, just so you can, just as an illustration, so you can see what we are envisioning. So, so if there are a total of 1,000 endpoints, maybe 300 of them are patient facing and 700 of them are clinician facing. Similarly, if there are 1,000 endpoints, maybe, 100 of them are version 1 versus, more of them hopefully are later versions of the implementation guide, et cetera. So we can break out that aggregate number into these components to help us better understand where industry is with regards to the adoption and use of different guides, different versions of FHIR, and also the types of endpoints that are being enabled. Next slide, please. Okay, great. So in terms of request for comments for this domain, Obviously, everyone is welcome to comment on any aspect of the measures that we've proposed. However, there are some specific questions or areas that we would like feedback on. So for the application supported through Certified Health IT measure, which is the app listing measure that I first went through, we would love feedback on the categories that we've proposed to characterize apps, specifically the definition of active use status, which right now we've defined as having 10 or more unique patients who've transferred their electronic health information during the reporting period as defining active use. So we'd really welcome comments on that specifically, as well as using the app registration process, as I mentioned, to collect this information. For the electronic health information export measure, we would be interested in learning the value and the level of effort for this measure to be further stratified by the intended use case. So whether that's moving data to another certified health IT system, use for a population analytics tool, and also the types of recipients. Are they patients? Are they other provider organizations of the exported data? For the use of FHIR bulk data access through Certified Health IT measure, similarly, we'd like to get feedback on the value and level of effort for further stratifications by intended use case, by the type of entity that's calling the API, as well as whether the query that's being made is automated versus an ad hoc query. And also what the value and level of effort might be in reporting on the number of authorized users calling a bulk FHIR API. And then finally, an area of interest for the last measure that I went through, the use of FHIR in apps supported by certified API technology. I described that, ONC's interest in really tracking the implementation of FHIR by looking at which versions of FHIR and US core implementation guides are being used. One question we have is whether the reporting on both of those is necessary, or would one of these be sufficient for understanding the implementation of FHIR? And if we were to pick just one, which one should we select as providing, better insights into the implementation of FHIR? With that, I'm going to hand it over to Dustin Charles, who will be walking us through the rest of the measures. Thanks.
Thanks, Vishali. Can we go to the next slide? Hi, I will be presenting on the individual access measures and the public health measures. So for the individual access to EHI measures, electronic health information, what we're looking for here is basically what methods are individuals using to access their health information. There's three sort of approaches that we are looking at. One is the third-party app technology, certified under the G10 criteria. Another is the apps offered by the health IT developer or the healthcare provider, again, under the G10 criteria. And then finally, patient portal technology, which would be under the E1 criteria. We're hoping that the answers to these questions, or to this measure, will help us refine and assess policies that have sought to increase individuals' access to EHI. Next slide, please. And the next slide, please, because I want to make sure everyone can see everything. Thank you. So we have three denominators for this measure that are divided into looking at sort of different populations based on whether or not the individual had an encounter, and whether or not the individual used at least one of those methods to access their information. So the first denominator here is just the number of unique individuals who had an encounter. The second is those who had an encounter and accessed their EHI using one of those methods that I mentioned. And then the third is the number of unique individuals who accessed their EHI using one of those methods, whether or not they had an encounter. And then the numerators for this measure will include the number of individuals who had an encounter and accessed their EHI at least once using one of those 3 types of methods, and the number of individuals who accessed their EHI at least once, regardless of whether they had an encounter or not. So both of these numerators will again be stratified by what method they used to access their health information. So those 3 methods based on the other slide. And we're hoping to get from that the percent of individuals with an encounter who access their information by at least one type of method, percent of individuals with an encounter who accessed their EHI by method, percent of individuals who access the EHI by at least one type of method. Is it twice? Oh, no, that's whether regardless if they had an encounter, sorry. And the other one is same. Okay, next slide, please. So I'm now going to talk about the public health information exchange measures. We have 2 types of measures here. One is the immunization administration measure that looks at whether the immunization administrations have been electronically submitted to immunization information system registries through certified health IT. The second measure is the immunization history and forecast, which captures the use of certified health IT to query for information from the immunization information system registries. The benefit of this measure is to inform public health preparedness by providing insights into the use of certified health IT to exchange vaccination immunization data both to and from IIS registries. So one of the questions we're hoping to answer here is to what extent are vaccine administrations successfully submitted to an IIS using certified health IT, and to what extent are immunization queries made to an IIS successfully responded to or received by a certified health IT. Next slide, please. So here are the numerators and denominators for those 2 measures. So the denominator for the immunization administration measure is the number of total number of immunizations administered during the reporting period. The numerator is the number of administrations from which the information was electronically submitted to an IIS registry successfully during the reporting period. The immunization history measure, the number of immunization queries sent during the reporting period, and the number of encounters during the reporting period will be recorded as the denominator. And then the numerator will be the number of query responses successfully received from an IIS during that reporting period. Both of these measures will be stratified by the IIS that they are sending or receiving information from, as well as age groups. We used adults 18 and over, adolescents or infants 17 and younger as the 2 age groups to stratify by. Next slide, please. So with these measures, we do have some requests for comments. So if you have any comments on them, we would love to hear a little bit more. One of the ways we are determining what a successful transaction of a measure is in these measures is by using the total number of messages submitted minus acknowledgements with errors. We propose that acts with an error, severity level of E, would not be counted. So our question for you is, should acts with a warning, the severity level of W, be counted in the numerator? The next question we have regarding submission to an IIS is, should successful submissions be counted if a provider is able to successfully submit at least one registry versus all of the registries to which a provider is submitted to? Secondly is thirdly, I apologize. Should a successful submission be limited to the first attempt to submit, or should replays qualify as successful submissions? In addition, for our stratification, should adolescents and infants be further stratified by age? And if so, by what age limits? And then our final question here is, can the number of immunization administered be linked to immunizations submitted to the IIS, effectively creating a subset of the numerator. Next slide, please. So some comments for the immunization history and forecast measure are, should both message types be included in the measure? So this is the HL7Z42 messages contain both immunization history and forecast, whereas the Z32 messages exclusively just contain the history. Also, we are considering some exclusion and inclusion criteria that we would love to have feedback on. Should the second denominator capture the total number of applicable patient encounters during the reporting period, regardless of whether a query was sent to an IIS? And then finally, we are proposing that developers of certified health IT with health IT modules certified to the F1 criteria would attest they are unable to report on this measure if they have no users that they administered immunizations to during the reporting period. However, there may also be providers who do not administer immunizations but would want to query to an IIS to determine whether their patient has received vaccination. So we see comments on whether we should include this exclusion or suggestions and how we could better refine that or capture that information. And then, as the same as the previous measure, should adolescents and infants be further stratified by age? And if so, what age limits would people suggest? Next slide, please. So the final slide here is a comment on our definition of encounters. So for the clinical exchange measures, the individual access measure, and the public health or the immunization measures, we've defined the encounters based on the NCQA outpatient set value and SNOMED CT inpatient encounter codes listed below. We see comment on whether to define encounters in this matter or include any type of visit, e.g. all encounters, in the measure denominator. Additionally, we see comment on alternative approaches to measuring encounters. Next slide, please. With this, I will turn this over to Stephanie Lee to close us out. Thank you.
Thanks, Dustin. Yes, so here are some resources that we wanted to share on our site. These are just additional resources to help the public commenting process. You can go to the next slide, please. So comments on the proposed rule should be submitted through regulations.gov. And then on our proposed rule webpage, we also offer a public comment template. It's completely optional, but it has been shown to help structure and organize larger amounts of comments, or if there's a very specific type of comment, the template sort of helps organize that. And then for comments specifically on the measure specifications themselves, we also have an ONC tracking project that's hosted on Jira. Here is where we accept comments specifically on the more technical specifications, as well as the proposed calculations that were just presented. Links to both the ONC tracking project and all the measure specification sheets are all available on our healthit.gov webpage. Next slide, please. And here's our contact info. Thank you so much.
One last thing, a couple of things I want to mention is that you do have measure specification sheets that are, if we go back a couple of slides, one more slide, yeah, that are, oh, sorry, one more slide forward. Forward, not backwards. Yeah, keep going. I think you're going backwards instead of forwards. So the next slide, yeah, right here. So in addition to the fact sheet, we also have measure specification sheets, which I think are at the way bottom of this page. Additionally, staff just put into the chat the website for providing specific feedback on the measures. So if you could please use that process for submitting any comments and questions, that would be wonderful. And then finally, we have 2 upcoming webinars related to other aspects of the rule. So next Thursday, May 18th, we have a webinar on the information blocking aspects of the proposed rule. And then on June 1st, I believe, which is a Thursday, we have a kind of overview of the entire proposed rule. So would welcome folks who are interested in attending those webinars because I think they're pretty informative. And then as Cannon mentioned, the slides and recording into today's sessions will be posted in the coming days. And I noticed that there's still some questions in the chat or in the Q&A. I'm slowly trying to go through these questions, so I'm happy to stay longer. And if folks have additional questions, please put them into the Q&A, and would welcome comments to be shared through the comments process that Stephanie outlined. Let me see if there's some questions that I might be able to answer live here. So I think Linda, you have a question, or I can answer live. So I'm going to click on the answer live button, but and I'll type in a response as well, just for the record. How will you be removing duplicate transactions of the same CCDA document? Right now, in the proposed rule, we are calling for the measures to be that relate to the clinical care information exchange to report on unique CCDAs. So, we would be asking those that would be reporting the information to remove those duplicate transactions. So, so that's how we've envisioned it in the proposed rule. And hopefully that answers your question, Linda. And then let's see, I think, would we need to collect all encounters across all practices or providers, or only Medicare relevant encounters? So the way that we've currently outlined the measure, I think across all the measures, because remember the encounter measure is a denominator across a number of different measures, including the patient access measure, public health information exchange measure, as well as the clinical care information exchange measure. And the way that we've defined it currently is broadly, so across all practices and providers. Again, it would be reported at an aggregate at the product level, so across users, end users of that product. So it's not limited to different payer types. Hopefully that answers that question. And then I think, the last comment here, how are developers supposed to get clients to agree to participate in gathering of this data to report on with real world testing effort presently? We have clients who have opted out of the ability for us to capture these metrics. As I mentioned in the beginning part of this presentation, we realized that there might be some specific hardships that developers may encounter. And so if you could please submit this as a comment, we can consider that as part of the process. So I would suggest you submit a comment in relation to that. And then I think, for the others, what I would suggest is, in terms of the definition, Kent, of defining an API deployment and whether, non-fire API versus fire-based API, those are definitional things that, I don't think are specified currently in detail in the rule. So what I would suggest is if you have a suggestion for how certain terms are specified, to provide a comment in the rule in relation to how you would suggest to further specify that. And similarly, for some of the other questions, I would suggest for the CCDA format, the conversion of the CCDA. Again, this would, someone anonymously has asked a question. Looking at the timelines, it appears that CCDA format will be required well into 2026. The conversion of the CCDA XML to the FHIR standard is just getting a review of usage, correct? That is something that I am not an expert on. I can't answer. And, what I would suggest is you can put in a comment related to that. And in relation, we can address that in relation to specific measure. The next question regarding the minimum 500 clinician user threshold, how are users counted? Based on your answer above, will CMS have the count, and how can we access that data? So this is described in detail in the proposed rule. If we go to the appendix slide, so if we keep moving the slides, advancing the slides, I think it's the first appendix slide. Yes, right here. Great. So the thresholds, since we've gotten a couple questions about this, maybe I'll spend a minute explaining this, is, we developed these thresholds, and this is described in the proposed rule in detail. We developed these thresholds based on linking CMS program participation data with ONC data on products, the Chapel data. And, we were working with data that was publicly available. We don't have access to the actual market share data of developers. So the thresholds that we have set were based on the best information that we had available. So you can see here for hospitals, at the 50 hospital threshold, what we found is only, 1.4%, or, we would end up covering approximately 99% of users. You could see encircled that 1.4, so 100 minus 1.4, 98.6, approximately 99. And about, 18 developers would be included in the program. And then this is based on 2019 CMS program participation data. So that's just an example looking at the inpatient market. And on the clinician side, the estimates that we have are, I would say, a little bit probably less accurate, just because not all clinicians participate in the CMS, Medicare program. For example, pediatricians don't participate. So, there are a number of gaps in that data. But again, based on what data was available to us, we set the threshold at 500. So what we would welcome is comments on whether these thresholds make sense when looking at the broader market, not just, based on the CMS data, and would welcome comments on that. So hopefully that answers your question. I mean, we set thresholds based on the best available data, but if others have other data sources that, we may have overlooked or are not aware of, that provides a broader set of data, not just on, clinicians and hospitals that participate in Medicare, please bring this to our attention. I think that's it in terms of answering all the rest of the questions. So thank you all for participating in this webinar. If there are any further questions or comments, please go to our comments page, as Steph mentioned, the JIRA page, to provide specific comments on measures. Thank you.